the language of science and medicine. You know, at first it sounds like lots of big words, confusing, but the big advantage is these words don't change over time. And so when we're working in a science or medicine, maybe we're trying to save someone's life, everyone understands what we're talking about. So when we say the word endocardium, myocardium, infarction, we all understand exactly what it means. And these words don't change because they're Latin-based. Let's go into a little more detail. For example, a patient comes in, diagnosed with myocardium infarction. Now, if we break that word down, myocardial means muscles of the heart. Infarct is to obstruct blood supply. So, we know something already just by knowing these two words. Well, actually, we know a lot. If it's a thrombotic kind of plaque, there's a big word there. That means the blood vessel is blocked and there's not enough blood supply, which relates to infarction. All right, are you getting the feel for this? These words have meaning and we get to use them again. All right, so here's the patient, 64 years old, chest pain, which pectoris, think of the pectoralis, chest muscle, angina, pain of the chest. What's causing it? Well, let's look at these coronary arteries. Okay, that means crown, and it's like a crown because we have the anterior, which is the front, descending. Perfect word, because front, downward orienting artery. There we have it. Well, if it's on the right side of the patient, then we call it right marginal. If it's on the left, we call it left marginal. Circumflex, think of like circumference or going around something. This goes around to the back of the heart. Now you might think, well, this must be wrong because this is really the left side. But no. We're looking down at the patient on the gurney. This is their right shoulder. This is their right coronary, right side of the heart. All right, very precise. All right, hypothesis. So now we have an observation. Here's our patient, and we don't know what's going on because they're breathing fairly normally. 15 with 12 to 16 is considered healthy for most adults. So what's our hypothesis or guess? Well, ischemic, so there's a blood supply issue. And maybe death of the tissue because that's where the angina comes in. When tissue starts dying, then we get impulses of pain. And so that's our hypothesis. Low blood supply, killing muscle cells. Okay, you starting to see how this works? It's like foreign language, you know, at first, but then you start seeing these trends, okay? Myocardial, heart muscle. All right, well, first thing, maybe, it depends on the patient. We might try to vasodilate, and that means we're going to expand those coronary arteries because maybe there's a blockage. Like, look at this example. We have a stenosis or narrowing of this blood vessel, and it's so narrow that the muscles of the heart are dying. So if we can just temporarily dilate that blood vessel with a nitrate-based chemical, nitro is just one of them, there's others too, then maybe we can get the pain to be reduced while we figure out what's going on. All right, so we're in the experimental phase. I don't like to think of medicine as experimental, but it often is because we don't always know what's going on. We might use a ECG or electrocardiogram. Electrodes, here we kind of see an example. A technician or nurse typically does this, and it's going to measure the impulses that leave the heart. This is why your heart beats. You have two nodes, a sino and a atrial ventricular node here, and they're going to expel these electrical impulses that cause the heartbeat. But if there's death, okay, if there's death somewhere of that myocardium, what's myocardium? Heart muscle. Okay, then the ECG may show ischemic changes. So let's take a look at this. Here's a normal sort of ECG. There's a P wave, QRS, and there's a T, okay? So that's what we expect when those nodes fire and make our heart beat. But if they have a STEMI, that means there's the ST segment is going to be elevated. And there you can see, okay, because look, here's normal, and here's the elevation, all right? And that can be serious. And there's also inversion waves I'm not going to talk about. But this little elevation of the ST wave can mean there's some muscle dying in the heart, which can cause death. There's also non-STEMI, which the ECG will show us there's a depression of the ST wave. All right, so STEMI means ST segment myocardial infarction. Now that's a big word, but we can break it down, right? Because we know infarction means heart muscle death when there's heart muscle, and now we know the ST wave. ST wave is, well, right here from here, QRS-T. There's the S wave, ST wave. Now here's an example I kind of like. All right, this heart was beating just fine, okay? There's a QRS and there's a T wave. But what is all this crazy stuff going on? It's a panic attack, okay? Anxiety can release hormones that cause arrhythmia. And so you can see how there's a lot of experimentation in science and medicine because we get surprises. It's really interesting. Okay, we've done ECG, but that's not enough, all right? We need to also look at the blood enzymes, especially troponin. Troponin is released when muscles of the heart die, all right? Because it's going to, the death of muscles of the heart releases troponin and also creatine kinase, all right? The problem, though, with creatine is sometimes, I mentioned here, it can be released even when people work out too hard, like overtraining. And so we can use the blood test in conjunction with the ECG. But the blood test alone sometimes can lead us down the wrong path. Now here's an example, okay? Here's a myocardium infarction event. You can see massive release of troponin protein and creatine kinase. And so you can just tell, okay, there was the heart attack, and now it's pouring into the bloodstream. Right? And these are called biomarkers. Now, I'm going to use the word thrombocyte because we're going to try to treat this, because here's an example. Here's a coronary artery on a electrocardiogram, right? We're imaging the heart. So what we're seeing is the anterior descending. Remember that word? Anterior front of heart, descending coronary. Perfect name. Right? So there is this is a right coronary, but there's a stenosis. What's stenosis mean? A narrowing, okay? There's a narrowing here, possibly because of some thrombosis or blockage. And the thrombocytes are to blame because when we have a blockage, it's often because of a clot. These thrombocytes, or platelets, same thing, are going to collect, and then fibrin's going to tie them together. And over time, this clot's going to get bigger and bigger, and it's going to occlude the blood vessel. And everything downstream from that blockage is going to die. And how do we know there's tissue death? Angina pectoris, chest pain. Okay, you see how these words are working? All right. Now, I said I'd talk about here's thrombolytic therapy. In thrombolytic therapy, what's happening is we are going to bust that clot apart. And we can't do this with everybody. And it has to be done early. And there's different ways, okay? An IV venous can be inserted or a catheter. And let's jump ahead because I want to see, this is be done on a stroke victim, but it's the same idea. What we have is a blockage. There's the blood clot, and once we drive the catheter through it, suddenly we get a flush of blood, and then we got to remove this clot. I'll get out of there. And so the catheter has a mesh, and it's going to pull it out. Ectomy to remove. All right. We might see it happen here in a few seconds. All right. Okay, well, let's get back to where I started. So are you seeing how science and medicine have their own language? And it's crucial because the protocols we must follow: observation, hypothesis, experimentation, and we all have to be able to communicate. There goes that clot. Maybe it just saved a life. Thanks for listening.